I'm going to talk a little bit about the current management of ischemic stroke. Most of it is going to be focused on the endovascular part. I'm gonna start with a little bit of history and how we ended up including the endovascular part in the guidelines, and then we'll go over what we're using right now here as far as the strokes and some of the imaging we use to determine whether the patient is a candidate for endovascular therapy or not. Ischemic stroke is when a vessel gets blocked in the brain. So if that thrombus breaks up immediately, it'll probably cause what is called a TIA, a transient ischemic attack. And if it doesn't, it'll cause a stroke. Okay? Ischemic stroke has 20% mortality and 40% disability, compared with hemorrhagic stroke, which is the other way around, with about 40% mortality and a little less disability, 20% disability for the ones that make it. So hemorrhagic stroke has a higher mortality. But about 80 to 90% of strokes in the U.S. will be ischemic, so that's why we put so much effort in trying to help these patients. We're going to have around 800,000 persons every year that are going to have a stroke, either new stroke or recurrent stroke. Our major risk factors, we all know them: atherosclerosis, cholesterol, hypertension, diabetes, smoking. Any patient that has a new onset of a deficit, neurological deficit, or any alteration in the level of consciousness, we need to consider that the patient is having a stroke. So we need to try to figure out if it's going to be ischemic stroke or hemorrhagic stroke. And the first line is going to be confirming the presence of the stroke with a CT scan. And for a lot of years, we just did that, just a non-contrast CT scan of the head. And from there, we started our medical management or try to figure out what's going on. And we're trying to change that right now, and we're trying to educate that the non-contrast CT scan is not enough. So we need to have a CT scan of the head with no contrast, but it needs to be followed up immediately by a CT angio of the head. We have the patient on the table. We just need to inject that dye, and we get a run from the chest all the way to the vertex, and we can assess the carotids and all the blood vessels in the brain. We're going to establish a baseline of the deficit, the severity, using the NIH stroke scale. And if it is possible, we'll try to determine the time of onset. And the treatment, the first treatment that we had was intravenous TPA, alteplase. And that was approved in 1996 to be used within 3 hours of the onset of the acute stroke symptoms. 10 years later, that window was extended to up to 4.5 hours, but there's some differences here. When we use the extended window from 3 to 4.5 hours, there are additional exclusions that may make the patient not eligible to have TPA. It was since 2006, there was no position of the FDA on that extended window. But then in 2012, they approved that extended window to 4.5 hours with additional exclusions. But there were several trials that showed that only 8% of the patients that had a high NIH stroke scale were going to have a favorable outcome with IVTPA alone. And when we talk about all these trials, when we talk about favorable outcome, we're going to talk about modifying Rankin scale of 2 or less. And that means that the patient is independent in the daily living. 3 would be moderate, but they need some assistance. 4 and 5 are severe disabilities, and 6 is death. So even 3, which is a moderate disability, it doesn't count as a favorable outcome in all these trials. So 2 or less is a good outcome. Advantages of IV TPA, well, we can administer very rapidly. Every single hospital has this available. It can be administered by any physician that knows the indications, contraindications for IV TPA. We only need a patient with stroke symptoms and a CAT scan that shows that it's not a hemorrhagic stroke, so no blood in the CAT scan, stroke symptoms within 4.5 hours. Patient will get a 0.9 milligrams per kilogram. That's the dosage. 10% of that dosage will be given as a bolus in 1 minute, and then the rest will be given over 60 minutes in an hour, and that's it. The efficacy will decrease with time, meaning that if the patient gets IV TPA within an hour of onset, it's going to be much better if he gets it at 4.5 hours after the onset. And it also decreases with the increased burden of thrombus, meaning that if the thrombus is occluding the ICA-T occlusion, which means the internal carotid artery, including the MCA and the ACA, that's a lot of thrombus, so 0% of those patients will get recanalized with IV TPA. If we get into smaller vessels, if it's a vascular artery thrombosis, about 1/4 of them will get recanalized. If it's just the ICA and the MCA that are thrombosed, also 1/4 of them. If it's a distal middle cerebral artery, it's going to be 1/3. A proximal middle cerebral artery is going to be just 15%. So the more clot we have, the less chances of the patient having a good outcome. And for this, the endovascular part, the endovascular industry has been trying to get new devices that can help these patients have better outcomes. So for years, they've been trying to develop several devices. We started with intraarterial TPA back in 1998, just using the same alteplase with a microcatheter directly intraarterially. Then we moved with the first thrombectomy device, which was called MRCLEAN device, in 2004. Then we did. We used some device that it was like a little basket. This was only approved in Europe in 2005. Then penumbra aspiration device. Those are large bore catheters that they're flexible enough to navigate intracranially, but they're large enough to be able to connect to an aspiration machine and just suck that clot out. Those were approved in 2009 by the FDA. And finally, what we call the stent retrievers. You may hear the patient had a stent retriever, or a stent retriever was used, or a stentriver. Those are the Solitaire and the Trevo devices. Those are self-expandable stents that can be retrieved. And the clot gets intertwined in the mesh of the stent, and it comes back with the stent. So those were approved in 2012 by the FDA. Solitaire is by Medtronic, Trevo is by Stryker, and those are the only 2 approved here in the United States. They were approved in 2010 in Europe. You may have read a lot. There has been a lot of trials trying to prove that endovascular therapy works, but they could never catch up with the technology. By the time the trial was done, there was a new device that showed that it was a little bit better than the other one, and it never showed truly that there was a difference between just doing IV TPA or doing endovascular therapy. But that changed in 2015. In January 2015, there were several trials that came out using the latest technology. They were very well randomized. The first one was the MRCLEAN Study, which was a prospective multi-center randomized trial in the Netherlands. They enrolled 500 patients in 18 sites, and the primary endpoint was that modified ranking scale less than 2 at 90 days, the ranking shift. And the other difference between all the other trials is the other trials never used CT angiography to confirm that there was a large vessel occlusion. If you go through all our activations, out of 10 patients that get TPA, probably 1 or 2 will have a large vessel occlusion. The other 8 will be small vessel occlusions that you don't see on a CAT scan, and the TPA works very well on them and they get better. So because the other trials didn't take that into account, there was never any difference because most of them will have a small vessel occlusion. But these trials took that into account and they randomized large vessel occlusions to just IV TPA and best medical management, which was the control arm, and best medical management, which includes IV TPA within 4.5 hours, plus thrombectomy. You can see here that the demographics are pretty evenly distributed, age and gender, NIH stroke scale. Both arms had the same median score. And here, in the pre-modified ranking scale, they were also very evenly distributed. So what did this show? It showed in red, you can see the control arm with just IV TPA, and in blue is IV TPA plus thrombectomy. Modified ranking scale of 0 to 2, it was 32% in the intervention arm versus 19% in the intervention arm. So it was a significant change in distribution. What was the main difference is that 97% of all the devices used were stent retrievers in the interventional arm. We can see here the ranking shift, which is almost 35% for the intervention arm of good outcome versus just about 19% with the control arm. This was the first study that was published in January 1st in the New England Journal of Medicine, and it was followed by another 4. Swift Prime was industry-driven, so this was paid by one of the stent retriever companies. They obtained reperfusion, and that's the stroke pager that we'll talk about in a minute. They obtained reperfusion TICI 2B or 3, which means that most of the territory of the MCA was open in 88% of the patients that went to the intervention arm. Again, it was solitary is the stent retriever, so solitaire plus TPA or TPA alone. It was very evenly distributed among the 2 arms, and they showed an even bigger ranking shift with the intervention arm almost to 45, almost to 50% of good outcome versus just 20% of the control arm. So almost 50% increase in chances of a good outcome. Also published in the New England Journal of Medicine. Again, Extend-IA did the same thing. And it was also published. This was investigator-initiated, multi-center randomized trial. They looked at they did a CTA 24 hours after both interventions, and they found that only 37% of the IV TPA patients will be reperfused against 100% of the ones that went into thrombectomy. And the modified ranking scale was 40% versus 71%. So big difference. Symptomatic intracranial hemorrhage, 0% with thrombectomy, again 6% with IV TPA, and the mortality was higher with IV TPA in this trial. a different study, they included patients up to 12 hours. They used CT perfusion to randomize these patients and to decide whether they were candidates up to 12 hours or not. And they assessed 316 patients also in the New England Journal of Medicine. 35% of patients with good outcome versus 18% with the control arm, so almost twice. And lastly, Revascat. It's they use again vessel occlusion within 8 hours. So some of them push that time limit a little bit further, but they use some advanced imaging to assess these patients. And the results, because this is dying. The results, this is 0, 1, 2, so you can see there's a big difference here in the control arm with the thrombectomy arm. So because of all these studies, in early 2015, the American Heart Association came up with an update of their guidelines for management of acute ischemic stroke. This is just a just a little refresher of what they mean when they talk about class 1. There's a strong evidence. It's indicated to do that procedure. 2A is recommended, could be beneficial, or is indicated it is beneficial. 2B, you may consider to do it if maybe there's nothing else better to do. And 3, well, we don't want to do we don't want to do that. So 1 and 2A would be the best. 1A would be the best, and that change here. IVTPA indication did not change at all. It's still class 1A evidence, so very strong evidence. We should do it if the patient is within the indications. And this is a new one. So endovascular therapy is 1A, so we should do it if the patient meets this criteria, which is a MRS pre-stroke of 0 and 1. So that means the patient is independent pre-stroke. The patient receives IVTPA within the guidelines, so within 4.5 hours. We have a CTA that shows that we have a large vessel occlusion. Patient is 18 years old over. We have an NIH stroke scale of 6 or more. And they include this Alberta Stroke Program Early Computed Tomography Score. It's called ASPECTS, and we'll talk about it later. So this is an imaging study. The score goes from 0 to 10, so we want a score of 6 or greater. And we can initiate the groin puncture within 6 hours of time onset. That's their recommendations. Now, we should try to achieve TK2B3 reperfusion, which is reperfusing most of the vessels that are occluded. Okay? TK3 is complete reperfusion with no single distal vessel occluded. 2B is a small distal vessel occlusion of less than 1/3 of the MCA territory. But basically, it's being able to retrieve that clot within 6 hours of stroke onset. Again, it's class 1, so it's strong. The evidence is not as good, some randomized trial. When it's beyond 6 hours, so the class goes down to 2B, which is, well, you may do it if it's the only thing you can offer the patient. It may or may not help. So we're not there yet as far as pushing the envelope past the 6 hours. But I think up to 8 hours, and we'll talk about this, every patient is different. We cannot rely only on the time of onset, and a lot of times we don't have the time of onset. So we'll rely on imaging for that. Well, this is for patients that have contraindications to IVTPA. If we can offer them endovascular therapy within 6 hours, it is recommended to get them to the endovascular suite. So the recommendation is strong. The evidence is not as good, but we should offer them that. So what are these stent retrievers? It's basically just a self-expandable overlapping stent, and it's attached to a pusher wire that cannot be left behind. It cannot be dislodged. So this is fused together, and we cannot leave this stent behind even if we push and pull too hard. So it's designed to not be able to be detached. They were approved in 2012 by the FDA with up to 6 hours of use with advanced imaging. They have shown TICI 2-3 recanalization in up to 90% of the cases, depending on the trial, with about 50% of patients with a ranking score less than 2 at 90 days. How do they work? So we have a clot. This is just a drawing of what would be the internal carotid bifurcation, MCA here, ACA here. We have a clot. We navigate a small catheter past the clot. Then we push that stent out, and as soon as it comes, the stent is compressed within the catheter. So as soon as it comes out, it's self-expandable. So it'll start to expand within the clot. It's going to cut through the clot, and the clot migrates inside the little tube, the stent. And then with that stent open, we just pull everything back out through a large bore catheter that we have at the level of the neck. And with some luck, we'll get that clot out in its entirety. Sometimes it takes several passes to be able to get the clot out completely, or to take the clot out in pieces. So this is a example of a 55-year-old male with left side hemiparesis. We got to the angio suite 5 hours after the onset. This is an angiogram of the right internal carotid. We have the ICA bifurcation here, MCA, anterior cerebral artery, and we can see that there's something missing here. So if you see the ACA territory, there's some distal vessels, and there's nothing here. So this is where the blockage is. This is the M1 segment. We pass a macrocatheter distal to that, and these 3 dots are the distal end of the stent. In this picture, the stent is open. You can see there's flow before, then an occlusion, then after we have flow. What happens is, as soon as the stent comes out, it creates a little channel, a small channel in the center of the clot that allows for some flow to go through. So right here, we wait between 3 and 5 minutes for that stent to completely expand and cut through the clot, and then we pull everything out. With some luck, we get a piece out. In this case, we got that piece out after 3 passes. So we pull everything out. If it doesn't come back, then we go back in again, do the same thing, go past the occlusion, deploy the stent, pull everything back again, and we repeat that until we get it out. So after the 3rd pass, we got the little piece out, and now you can see the distal, how it should look, which is all these vessels reperfusing the MCA territory. 24 hours, we got a CAT scan. This was the stroke that the patient had, a little insular stroke there, lenticular nucleus. The rest was fine. The patient did very well. Another example, 1052, we started with, in this case, is the left MCA that's blocked. There's nothing here. And this, after 1 pass, we were able to just retrieve that little clot. We can see that elongated clot at 11:11. So just about 20 minutes after, we were able to reperfuse. So this time window, this is what we have. I mean, we will go by the 6 hours, but is it really clear cut, and is it really useful? Well, you have this patient here with the onset of symptoms at 8:30 a.m. NIH stroke scale of 5. This is the initial CAT scan. The first angiogram was done almost 12 hours later. Okay? And the patient had an occlusion here. You can see there's some vessels missing here. It was not an M1 complete occlusion. It was an M2 occlusion, a little bit more distal. Okay? Recanalization was done at 7:50 p.m., so almost 12 hours later, 24 hours after NIH stroke scale was 0. This was the little stroke that the patient had, an insular stroke. Why did this patient lasted almost 12 hours with an occlusion? And this one, with the onset at noon, CAT scan 3 hours later, onset at noon, this is the CAT scan 3 hours later. You can see that 3 hours later, there's already a huge MCA stroke. So why 3 hours later? I mean, by any means, this would have been an endovascular candidate. This would have been an IV TPA candidate because it's 3 hours later. Well, every patient is different. Every physiology is different, and it all comes down to the collateral flow. Each of us have different collaterals. The ones that have better collateral will last longer without proximal occlusions. The ones that have absolutely no collaterals, if you don't have flow for 30 minutes in that MCA territory is dead. And there are patients that have 0 collateral. So it'll determine how much time the patient can sustain that decreased flow. And a good collateral means that if we do a 3-phase CTA of the head, and we'll probably move to this instead of the CT perfusions that we're doing, because it's much easier to do. Good collaterals means that both sides, just visualizing both sides, you have evenly distributed flow despite a proximal occlusion. So you have a proximal occlusion, but distal to that, you're still getting flow somehow. That means the patient has good collateral flow. Intermediate collateral, so these are the patients that probably last up to 12 hours with a proximal occlusion, and then you get them to the suite and they do great. Then intermediate collaterals, there's still some distal flow past the occlusion, not as good as the good side, but these are the ones that probably last up to 6 hours, maybe 8 hours, because they have somewhat of good collaterals. And poor collaterals, this is on the other side, means there's almost no vessels seen in a 3-phase scan past the occlusion. That means patient gets an occlusion and automatically there's ischemia. There's no 6-hour window or 3-hour window, because after 20 minutes or 10 minutes, that MCA territory is dead. And how we do this is just we do the initial CT scan from the thorax to the vertex, and then we just go down and repeat the head 1 time, 2 times, 3 times with no additional contrast. We just repeat that CT head. And we get these scans and we can assess that collateral flow. So what do we need to do? If you have a patient in your unit or wherever you're covering that has stroke symptoms, first thing is to get that CT non-contrast in a CT angiogram. If there's hemorrhage or there's already a large stroke because the patient didn't have collaterals, then we're going to stop. I mean, we're going to start medical management, conservative management, or the hemorrhagic stroke management. If there's no hemorrhage and the patient is within 4.5 hours, we are going to give TPA. And if that CTA showed that there's a proximal vessel occlusion, meaning an ICA, a vascular artery, an M1 artery, and the aspects score is from 6 to 10, with the TPA hanging, we immediately take the patient to the neuro suite and we start thrombectomy. If there's no branch occlusion, no major branch occlusion, or if there's already a large stroke, then we stop. We don't do endovascular management. When you have a stroke patient, you call the operator, tell him to just page the stroke team. The operator will page 143 and the unit where the patient is having the stroke. So anyone activating Dr. Stroke will activate this 143. And then all these codes we're using to communicate amongst us in the stroke team. Neurology will probably be the ones that will first see the patient, and they are going to assess the patient for TPA. If the patient is a TPA candidate, the patient's going to go to the CAT scan. So right now, I got that stroke. There's a stroke patient, and I'm still waiting for, this will be the first code that I'll be waiting for, the 000, where radiology is going to tell me that the scans are done. Now I can go in, because I cannot take any patient if I don't see a scan. Unless I have confirmation that there's a large vessel occlusion, I'm not taking the patient to the angio suite. So I'm waiting for this. Once I have this, then I'll go into the chart or into PACS, and then I'll check that and review the CTA, review the non-contrast CT. From my part, if it's an endovascular candidate, I'll page this 222 so everybody will know that this is a endovascular case, and we activate the IR team, we get the neurosuite ready, and go from there. If that patient is also a TPA candidate, then neurology will start TPA in page 143, 100, and we get the patient with the TPA hanging, get the patient to the neuro-IR, and we'll just page that we've started the procedure with 243. If it's not an endovascular candidate, I'll page 286, and everybody will know that that patient is not going to angio. They can proceed with the medical management. Same goes for TPA. They'll page 186 if it's not TPA candidate or if it's not a stroke. But basically, this one, 143, is the one that anyone that sees a patient with symptoms will activate. And then second code we're waiting for is this 000, because neurology needs that imaging too to determine if they're going to give IV TPA or not. 333 is if it's a hemorrhagic stroke, then neurosurgery knows that they have to go down there and check on the patient. So what's that aspects that we've been talking about? So that's a 10-point score on a non-contrast CT scan. Okay? And because the CT scan is the first line diagnostic test, this was and is widely available. We're trying to determine a score that would tell us whether the patient was a candidate for endovascular therapy or not based on that non-contrast CT scan. So what we're going to look for on the non-contrast CT scan is a frank hypodensity. A frank hypodensity tells us that part of the brain is dead. But if there's cortical swelling, if we have loss of gray white matter differentiation, that means that the changes are too far along, and that part is going to be dead anyway, so we should not do anything. We look for that hyperdense MCA sign. It's just a normal non-contrast CT scan. And all the trials that I showed showed that an aspect of 6 to 10 was associated with a greater benefit after endovascular therapy. So we're going to start with 10 points, and we're going to subtract a point from each region that shows changes. And these are the 10 regions that we're going to look for. They're better to be seen here on a CAT scan. So this is your non-contrast CAT scan. We're going to get a view through the basal ganglia, and we're going to have our deep basal ganglia structures, head of the caudate, lenticular nucleus, internal capsule, and insular ribbon. And then we're going to have our anterior MCA territory, lateral MCA territory, M2, posterior MCA territory, M3. And we will get a second cut above this level. We're going to get anterior MCA territory superior to the previous level, lateral MCA territory above the previous level, and posterior MCA territory. So these are the 10 levels here. M1, M2, M3. Above that, M4, M5, and 6. And the deep structures, the caudate, lenticulate, internal capsule, and the insula. So those are our 10 points. We have them here. You could use just 2 cuts, one through the basal ganglia and one above that. So these are examples. Patient has an MCA, hyperdense MCA, and a CTA showed a M1 occlusion. One cut through the basal ganglia, one cut above it. We compared to the contralateral side. And in this case, we have M1, M2, M3. They look the same as the contralateral side. M4, M5, and 6, they look the same as the contralateral side. Insular ribbon, the same. Head of the caudate, internal capsule, and lenticulate nucleus is the same. So those are the 10 areas that we look for, and we gave an aspect score of 10. The onset was at 5 p.m. CT was done an hour later, so it correlates very well with the time of onset. Another patient, hyperdense MCA sign, one cut through the basal ganglia, one above. We compare M1, well, this is already dark. The insula is already dark. Internal capsule, already dark here. That's 3 points less. M2, lateral to that, well, maybe it's the same. M3 is the same as the contralateral side. And then above, M4, already dark. M5, already dark. M6, already dark. So these are the 10 regions. All these were given as already with changes. So this gives an aspect score of 4. This is before we started using aspect score. So 5 p.m. of onset. This was done at midnight. Patient was taken to the angio suite. We opened up this patient. Everything was pretty good in the angiogram. And this is what happens if you open those patients up. Okay? Basically, we increase the flow to dead tissue. It gets severe swelling and herniation. The patient died. And I think there was a patient yesterday that was transferred. CAT scan looks something like this. We were trying to get him here in time, but it was an aspects of 4, so we just didn't touch the patient. Another example, aspects of 10 pre with a stroke scale of 12. CT scan shows a cutoff here. Of course, we scroll up and down and we try to get coronals and sagittals, but you have to believe me, there's a cutoff here. And this is the angiogram here. We see the cutoff in the MCA. Opened up that vessel pretty nicely. And this is the 24 hours later CT scan, aspects of 10, stroke scale of 2, 24 hours later. So it does work. The aspect score, CTA, is the minimum that we require to decide whether the patient goes to the angio suite or not. Then, if we have available CT perfusion, it's a nice tool to use. We are doing them to get our techs trained, but we're not actually looking at the perfusion because they have to be post-processed. We don't have a workstation in the ER CT scan, so those images need to be sent to the second floor reading room. Somebody has to go up there and process the images, so it takes a lot of time. So we're not actually looking at them, but probably in the future we will, or we'll just move to that 3-phase CT angiogram. And there's 3 things that we look at: cerebral blood flow, blood volume, mean transit time. When all these 3 match, that's going to be our core infarct, that's dead tissue. When there's a mismatch, between the blood volume and the transit time, then that's our penumbra. That's the tissue we can save. And when our core infarct is more than a third of the MCA or more than 1 cc of tissue, 100 cc's of tissue, that's going to exclude our intervention. So, and these are not hard to read. It's just that they take time to process and get these color maps. Our blood flow in a stroke will always be decreased because you don't have flow there. Okay? Our blood volume is basically our analog to collateral flow. If we have good collateral flow, that territory will have its blood volume preserved. And the mean transit time, it means how long that contrast or that blood takes to go out of that territory. And because this is retrograde flow through collaterals, it takes longer to get out of there. Okay? So blood flow will always be decreased. Mean transit time will always be increased because it's going to take longer. And the key one is going to be the blood volume. If the blood volume is preserved, that brain tissue is still alive. We take the, and if this is, if it's preserved, or if the core infarct is less than 100 cc's, then we take the patient to the unit, to the angio suite, and regardless of if it is 8 hours or 10 hours, if it's still preserved, then we can still save it. If the blood volume is decreased and it matches the flow and the transit time, then that tissue is dead and we don't take the patient to the angio suite. So in this case, compared with the contralateral side, blood flow is decreased, mean transit time is increased. We said that's for any patient. But the blood volume, you see, is the same as the contralateral side. So this is good collateral flow, and all this tissue is at risk, but it's still alive. So this is a mismatch between these. Now this patient has decreased blood flow, increased transit time, but compared to the other side, this is in red, so this area matches, the blood volume is decreased, so it matches the other two. So, and this is more than a third of the MCA, so the core infarct is large, all this territory is already dead, so this patient is not a candidate for thrombectomy. So that's what we need. So right now the only limiting factor is the time it takes for this to be processed. There are softwares that do it automatically that you can have next to the CT scan, and they give you this in an instant, but we don't have that here yet. So after we take the patient to the angio suite, all these patients are going to be going to the MICU, so what are we going to do for them? Number one, we get a CAT scan right after the procedure, and most of the times I ask the team in the IR suite to take the patient to the CAT scan and then to the ICU. So we want that CAT scan right away. Maybe sometimes that gets lost in communication and the patient goes to the ICU. If the patient doesn't have a CAT scan when they get to the ICU, they need to get one immediately. And then we'll get one 24 hours later. If we were successful in reperfusing, we want our blood pressure below 140 because we don't need any hypertension anymore. There's flow, so we want to control that blood pressure to be on the low side or less than 140. We want to avoid hemorrhagic conversion. We're going to do groin checks every 30 minutes for 2 hours, then every hour for another 4 hours. And that's if there's no TPA on board. If there's TPA on board, then we're going to do that more often because there's increased chance of having bleedings from the access side. So we're going to do every 15 minutes for an hour, then every 30 minutes for 2 hours, and an hour after that. Neuro checks, We want every 15 minutes for an hour, then 30 minutes for 2 hours, and then an hour after that. Any change in the neuroexam, immediate CT head without contrast. Any drop in the hemoglobin or any drop in the blood pressure, especially if the patient has TPA on board, that's a CT abdomen and pelvis without, and we have to ask them to include the groin and that stat to evaluate for any bleed from the access site or from any other source in the abdomen. So even with the best care, some of them have hemorrhagic conversion. If there's no TPA on board, we just offer a blood pressure control and a neurosurgical consult, and we go from there. If it's bad hematoma hemorrhage and there's midline shift, patient probably will go to the operating room. Now, if there's TPA on board, we do the same thing, but there are no guidelines or no protocols that are confirmed as working for reversal of TPA, but this is one that I'm putting here that it's based on the physiology of the TPA and what's going on with the hemorrhage. So we want to control that blood pressure aggressively. We want to give immediately Amicar, which is aminocaproic acid, which is going to inhibit the plasminogen. We give 5 grams IV bolus over 15 to 30 minutes. We immediately check our fibrinogen. If it's less than 100 milligrams per deciliter, we give 10 units of cryoprecipitate and then repeat the fibrinogen. If it's still less than 100, then we repeat another 10 units of cryoprecipitate. If there's a known platelet disorder, we give 6 units of platelets. Or if the patient has ReoPro for any reason, sometimes I use ReoPro during my procedures. So that's going to inhibit the platelet aggregation, so we need to give platelets to try to reverse that. If there's continued bleeding after that, you can consider 10 grams of Amicar over an hour, but there's a high risk of pathologic thrombosis at other sites with that. But I mean, if the patient is having intracranial bleeding, I guess we should do that, because otherwise the patient's going to die. So in summary, mechanical thrombectomy has now the same place as IV TPA in the management of ischemic stroke. I didn't go into the MRI because in all studies it was discouraged to get an MRI as first-line treatment. All these patients will get an MRI 24 hours later after we've stabilized them. But there's no need for one in the acute setting. If you have a patient with a stroke, place that order for the CT and the CTA at the same time with patient-doctor stroke. We're going to give IV TPA if it's indicated, and we're going to roll the patient to the angio suite if we find a major branch occlusion and we find that the aspect score is going to be more than 6. Thank you. Any questions?
So in this day and age of being able to email pictures and all that kind of stuff, do you use, when you get called from Alexandria or anything like that, do they text you pictures so that you can figure out scores, or do you just bring them up? Or?
No, the main problem we have with all these other hospitals is, well, a lot of the small ones don't have CT angiography. So we're trying to accept all patients with ischemic stroke symptoms, with stroke symptoms. And once they get here, we'll get that CT angio to determine if they're endovascular candidates or not. If they do have CT angiography, they'll probably have some teleradiology or somebody reading, and I go by the read of that. If they tell me, radiology said there's an MCA occlusion, CT scan show it's clean, there's nothing, then okay, we bring the patient over. That's something that happened yesterday. but it just took a lot of time for the patient to get here, so it was too late. It was, when the patient was at the outside hospital, he was still a candidate, but 2 hours later, it was not. And for all these patients, even with a confirmed CTA occlusion, once they get here, they need a new CT scan. Because an hour makes a lot of difference. If it's an hour, it makes a lot of difference. So maybe the CT scan over there was clean. In an hour later, there's already a huge stroke. So we at least get a new CT scan when they get here.
You see a lot of catheterization, like you're trying to keep the bronchus.
No, most of the reperfusions that we get are on the 2B side, which means there's still some distal vessel occlusion. The stent retrievers, they don't break up the clot as much as the other devices previously, so we don't see as much distal embolization. There is some, but they're usually small enough that they don't impact the outcome of the patient.
So if we're on call and a stroke code comes in, neurology, sorry, would you rather us, instead of ordering a CT perfusion, could we just ask them to do a 3-phase CT so that?
Well, that's something I'm going to talk about in the next stroke meeting, because there has to be a lot of people involved. We need to talk to all the techs again, and we need to change the order set to reflect that it's a 3-phase CTA. But hopefully in the next couple of weeks, we'll switch from that CT perfusion to the 3-phase CTA.
Can we order, like, say someone comes
There's no order for a 3-phase CTA, so.
Oh, we can't order it.
No.
I mean, like, if someone comes in and they're within the window and they, like, on exam, we think they have a proximal occlusion, they would probably be a good endovascular candidate. Could we just go ahead and ask them to do a 3-phase CT, you know, in addition to?
They don't know how to do it.
They
right
don't,
now.
okay, never mind then.
So, several things varying kind of all at the same time that's relevant. The consistency of the clot is presumably changing over time, or it's growing. Part of it's one consistency, part of it's a different consistency.
So over time, it gets more organized.
Right.
And
So it needs to be organized enough to hang together when you pull,
Yeah, exactly.
but not so much that it won't be cut
Just break
through.
off.
Yeah.
By the time, I mean, honestly, probably the fastest you could get a patient is someone that has a stroke in the hospital, and maybe 45 minutes later you get him on the table, or 30 minutes later. That's time enough for that clot to get organized and be pulled out. Now, from experience, from other interventions that I do, when we have a little clot that goes up, when we see it, sometimes with our little guide wires, we can just break it up. We just put a guide wire and kind of roll it around the clot, and it breaks up into little pieces and goes away. So time definitely helps. Now the other part is when patients have IV PPA on board, that clot may break up easier than without it. But breaking the clot into small little pieces allows that PPA to keep working and dissolve any distal clots that we may break up and send distal.
Is there ever a risk that as you're pushing, you actually, if it's solid enough, that you actually impact it and increase blood flow?
The catheters are very small, and what we do is we advance the little catheter distal to the occlusion until we see flow. We inject contrast distal to that occlusion. We make sure there's no clot past the tip of our catheter. And that way we can deploy our stents covering the whole occluded segment. So we can we may push it further a little bit, but because we're always distal to that clot and covering everything with the stent, we get it all out. And the catheters are on the order of half a millimeter in size. Well, thank you. Any questions? You can email me or